In this video, we are going to learn about the normal electrical conduction pathway of heart, definition of AV block, types of AV block like the first degree heart block, Mobis type 1 second degree, Mobis type 2 second degree and third degree heart block, with definition of each blocks, with the features, mechanism and causes of all the type of atrioventricular block, clinical significance of them as well as the treatment. The cardiac conduction system is a specialized network of muscle fibers that initiates and propagates electrical impulses causing the heart to contract and pump blood. The electrical pathway consists of SA node, which is the pacemaker of the heart. The only electrical window between the atrium and the ventricle is the AV node. Then the impulse transmitted via the bundle of His into the bundle branches, then ultimately to the Purkinje fibers. Atrioventricular block or AV block is a heart rhythm disorder that occurs when the electrical signals traveling from the atria to the ventricles are delayed or interrupted. AV nodal blocks are of three types: first degree, second degree and third degree. The second degree AV block also classified into two types, Mobis 1 and Mobis 2. First degree heart block. First degree of heart block is marked when PR interval is more than 200 millisecond or 5 small squares. There is delay in the electrical conduction from the atria to the ventricles, but there is no interruption in the conduction of the electrical impulses. In the ECG, we'll get PR interval is more than 200 milliseconds or more than 5 small squares, and each P wave is followed by QRS complex. The causes of first degree heart block are increased vagal tone, athletic training, inferior MI, mitral valve surgery, myocarditis, electrolyte imbalance like the hyperkalemia, AV nodal blocking drugs. Mnemonics is the ABCD like amiodarone, beta blocker, calcium channel blocker and digoxin. It may be also seen as a normal variant. Clinical significance: as an isolated findings, this is a benign entity that does not causes hemodynamic instability. Treatment: no specific treatment is required. Second degree heart block. The Mobis type 1 second degree heart block is also known as the Winkie-Back phenomenon. This is named after Dutch physician Karel Frederick Winkie-Back. He is credited with describing the specific pattern of progressive lengthening of the PR interval followed by a dropped QRS complex, which is characteristics of this type of heart block. Definition of Mobis type 1: there is progressive prolongation of the PR interval resulting in a non-conducted P wave. PR interval is longest immediately before the drop beat and the PR interval is shortest immediately after the drop beat. Other features include the PP interval remains relatively constant. The greatest increase in the PR interval duration is typically between the first and the second beat of the cycle. The RR interval progressively shortens with each beat of the cycle. The Winkie-Back pattern tends to repeat the P is to QRS group with ratio of the 3:2, 4:3 or 5:4. If we take example for the 3:2 pattern, in the ECG lead 3 P waves, there would be only 2 QRS complex. The Mobis type 1 usually reversible conduction block, and this block occur at the level of the AV node. Due to the AV nodal cells malfunction, the cells become progressively fatigued. There would be progressively delay in conduction. Ultimately, the AV node fails to conduct the impulse coming from the SA node. Thus, in that cycle, the P wave will not be followed by QRS complex. The causes of type 1 second degree AV block are increased vagal tone, athletes, inferior MI, myocarditis, cardiac surgery like the mitral valve repair or the tetralogy of Fallot repair. Also the drugs, amiodarone, beta blocker, calcium channel blocker and the digoxin. Clinical significance: Mobis type 1 is usually benign rhythm causing minimal hemodynamic disturbances with low risk of progression to the third degree heart block. Asymptomatic patients do not require treatment. Symptomatic patients usually respond to atropine. Permanent pacing is rarely required. Definition of the Mobis type 2 block, that is also called the Hay block. This is a form of the second degree AV block in which there is intermittent non-conducting P wave without progressive prolongation of the PR interval. In the type 1, there is progressive increase in the PR interval and then there is a non-conducted P wave. That means there is absent of QRS complex. But in the type 2, the PR interval is not progressively increased or not progressively prolonged. That means the PR interval remains constant. Instead of this, there is intermittent non-conductant P wave. That means there is dropped QRS complexes. Other features include the PR interval in the conducted bits remains constant. P waves march through a constant rate. The RR interval surrounding the drop bits is exact multiple of the preceding RR interval. For example, as we can see from the ECG strip, the RR interval is 4 large squares. On the left side, there is one drop bit. For that, we get the RR interval in that scenario 2 times of the RR interval where the P waves is followed by QRS complex. In the strip, the RR interval is 4 large squares. Thus, in the left side where there is one drop bit, we get the RR interval 2 times of the 4 large square. That means the 8 large squares. On the right side, as there is 2 drop bits, where we get the RR interval 3 times of the 4 large squares. That means the 12 large squares. Mobis type 2 usually due to the failure of conduction at the level of the His-Purkinje system below the AV node, while the Mobis type 1 is usually due to the functional suppression of the AV conduction due to the drug or the reversible ischemia. Mobis type 2 is likely to be due to the structural damage to the conductance system like the infarction, fibrosis or necrosis. Patient typically have a pre-existing left bundle branch block or bifascicular block, and the second degree AV block is produced by intermittent failure of the remaining fascicle. In around 70% of the cases, the conduction block is located distal to the bundle of His, producing a broad QRS complex, and 25% of the cases, conduction block is located within the His bundle system that produces narrow QRS complexes. Mobis type 1 is produced by the progressive fatigue of the AV nodal cells, but the Mobis type 2 is an all or none phenomenon, whereby His-Purkinje cells suddenly or unexpectedly fail to conduct a supraventricular impulse. There may be no pattern to conduct the blockade, or alternatively there may be a fixed relationship between the P waves and the QRS complexes. That means 2:1 or the 3:1 block. Causes of Mobis type 2 block are necrosis of the bundle branches due to the septal infarction, idiopathic fibrosis of the conducting system, cardiac surgery, especially the surgery occurring close to the septum like the mitral valve repair, inflammatory conditions like the rheumatic fever, myocarditis, Lyme disease, autoimmune diseases like the SLE, systemic sclerosis, infiltrative myocardial disease like amyloidosis, hemochromatosis, sarcoidosis, hyperkalemia, drugs like amiodarone, beta blocker, calcium channel blocker, and digoxin. Clinical significance. Mobis type 2 is much more likely than the Mobis type 1 to be associated with the hemodynamic compromise, severe bradycardia, and the chances to progression to third degree heart block is also more. Onset of hemodynamic instability may be sudden and unexpected, causing a syncope or sudden cardiac death. The risk of asystole is around 35% per year. Mobis type 2 mandate immediate admission for cardiac monitoring, backup temporary pacing, and ultimately insertion of permanent pacemaker. The third degree heart block or the complete heart block occurs when there is severe bradycardia due to absence of AV conduction. There is AV dissociation with the atrial rate about the 100 beats per minute and ventricular rate about 40 beats per minute. In complete heart block, there is complete absence of AV conduction with none of the supraventricular impulses conducted to the ventricles. The perfusing rhythm is maintained by junctional or the ventricular escape rhythm. Alternatively, the patient may suffer ventricular standstill leading to syncope or sudden cardiac death. The complete heart block is essentially the end point of either Mobis type 1 or the Mobis type 2 AV block. It may be due to the progressive fatigue of the AV nodal cells as per the Mobis type 1, secondary to the increased vagal tone in the acute phase of the inferior MI. Alternatively, it may be due to the sudden onset of the complete conduction failure throughout the His-Purkinje system as per the Mobis type 2. This can be secondary to the septal infarction in acute anterior MI or as a result of progression of conductance system disease causing true trifascicular block. The complete heart block due to the Mobis type 1 is more likely to respond to atropine and has a better overall prognosis. Causes of complete heart block. The causes are same as the Mobis type 1 and the Mobis type 2 second degree heart block. The most important etiologies are inferior myocardial infarction, AV nodal blocking drugs and the calcium channel blocker, beta blocker or the digoxin, idiopathic degeneration of the conducting systems causing the true trifascicular block. Clinical significance. Patient with third degree heart block are at risk of ventricular standstill and sudden cardiac death. They require urgent admission for the cardiac monitoring, backup temporary pacing, and usually insertion of permanent pacemaker. Differential diagnosis. Complete heart block should not be confused with high-grade AV block. High-grade AV block is a type of second-degree heart block with a P is to QRS ratio of 3 is to 1 or higher that produces an extremely slow ventricular rate, but still some evidence of the occasional AV conduction. Second differential diagnosis is the AV dissociation. This term indicates only the occurrence of independent atrial and the ventricular contraction and may be caused by entities other than the complete heart block.